Good afternoon. As many of you know, this is the week at Columbia when we are privileged to welcome presidents, prime ministers, and global policymakers to campus, each of them a world leader who comes here to express his or her views and to engage especially our students directly on the most pressing issues facing societies. For several reasons, this particular Columbia World Leaders Forum stands out on the calendar and carries very special significance for our university community. First and foremost, we are very happy to have the opportunity to hear from Dr. Tedros, who became the Director General of the World Health Organization in July. In addition to welcoming you to Columbia, Dr. Tedros, we offer you our congratulations and our best wishes for you as you begin your term as Director General. The World Health Organization is responsible for addressing the most serious public health challenges facing humanity, from emerging pandemics and antibiotic-resistant infections to the health effects of climate change. Indeed, these matters have for some time occupied the focused attention of a large number of this university's scholars across our campuses and at our global centers. And so we have been honored that the WHO designated Columbia's International Research Institute as a partner in predicting disease outbreaks resulting from climate change. Dr. Tedros is especially well-suited to shoulder this responsibility. During his tenure as Ethiopia's Minister of Health, he vastly expanded access to quality medical care by instituting fundamental reforms in the nation's healthcare system. He also served as Ethiopia's Minister of Foreign Affairs. I know we are all looking forward to hearing about his plans for the World Health Organization. Second, today marks the launch of a new Columbia program on global health, security, and diplomacy. This is a cross-disciplinary effort involving the Medical Center, the School of International and Public Affairs, and the Earth Institute's International Research Institute for Climate and Society. It will be led by Dr. Wilmot James and Dr. Madeline Thompson. Dr. James, who will moderate the panel following Dr. Tedros' address, was for several years a member of South Africa's parliament and provided leadership to that nation on a range of public health matters in a ministerial capacity. He is a visiting professor at the Columbia University Medical Center and at the School of International and Public Affairs. Third, this event provides us with an opportunity to take stock of how the university is helping to address problems of global dimension, especially at this consequential moment in world history. And it is important for Columbia to be pondering its responsibility in this regard, and we have been. Global society's challenges are more sharply delineated than ever before. All I have to do is say that with emphasis, and everybody knows what I mean. And it has become increasingly clear that 20th century institutions and norms are not sufficient for addressing the complexity and scale of these problems. And with this in mind, we have launched a far-reaching new initiative called Columbia World Projects, a development that will, I think, have a profound effect on research, teaching, and scholarship at Columbia in the coming years. Its central purpose is to harness the university's capacities and knowledge in the service of practical solutions, always with an openness to, even an insistence on, working across, but even beyond disciplines, and with partners beyond academia. Following the remarks of Dr. Tedros, we will be hearing from a panel that includes Elizabeth Cameron, who has become a senior director at the Nuclear Threat Initiative after serving on President Obama's National Security Council. Gavin Schmidt, the director of NASA Goddard Institute for Space Studies at the Columbia University Earth Institute, and our well-known Jeff Sachs. For all of us know and appreciate the extraordinary leadership he has provided to this university and to the United Nations and beyond on sustainable development and far more. We thank all of you and our speaker, Dr. Tedros, for the contributions that you are making to improve global health and well-being. Now please join me in welcoming the World Health Organization's new Director General, Dr. Tedros.
Thank you very much for that kind introduction. Dear President Bollinger, my brother Professor Sachs, distinguished colleagues, ladies and gentlemen. Before I begin my address, let me first express my deep personal concern for the people of the Caribbean islands as they suffer this relentless wave of hurricanes. This is a further reminder of the merciless consequences of our changing climate. Shattered homes, shattered lives. WHO stands ready to do all we can do to assist. But now let me take you on a journey. It starts with a single case in a military camp in Kansas. A cook reports to the medical center complaining of fever, a sore throat, and aches and pains. Within minutes, a second soldier is admitted with similar symptoms. By lunchtime, the count has reached more than 100, and more than 500 by the end of the week. The following week, the virus reached New York, Manhattan. Battalions from the camp are sent to fight a war in foreign lands. There, confined living quarters and massive movements of troops provide the ideal conditions for the virus to spread. Within months, the epidemic sweeps across 5 continents. Its symptoms include nausea, diarrhea, and dark spots on the cheeks. As the virus takes hold, patients turn blue and suffocate as their lungs fill with blood. There are no vaccines to stop the virus and no drugs to treat it. Many of its victims are young, cut down in their most productive years. Schools, places of worship, theaters, and other public places are closed. Here in New York, businesses' closing times are staggered in order to avoid congestion on public transport. Funerals are limited to 15 minutes. There is a shortage of coffins. And then, as suddenly and inexplicably as it started, the pandemic ends. 1/3 of the world's population has been infected, including 25% of the US population. 50 million people are dead. This is not some future apocalyptic scenario. This happened as you may know, 100 years ago, the so-called Spanish flu, which may in fact have started here in the US, killed more people than the First World War itself. And yet it was overshadowed by the war and faded quickly from public awareness. Its lessons are just as relevant today as they were then, that a devastating epidemic can start in any country at any time and kill millions of people because we are not prepared. But we do not have to stretch back that far to be reminded of the fearsome consequences of epidemics. Just this century, we have witnessed outbreaks of SARS, H1N1, H5N1, MERS, and H7N9. Each of these has resulted in deaths, sickness, fear, and economic loss. Of course, the most dramatic epidemic of our time was the Ebola outbreak of 2014 and 2015. Although it affected 3 poor Western Africa countries, it exposed fault lines in global health security that put us all at risk. Its severity was caused in large part by weaknesses of the health system, which were ill-equipped to detect or track Ebola, and were soon stretched beyond their limited capacity to respond. It was not just the Ebola virus itself which killed. In Liberia, the epidemic contributed to a 61% decline in outpatient visits. Sierra Leone experienced a 39% drop in children being treated for malaria, and a 21% drop in children receiving basic immunizations. You know what could happen to these kids. In Guinea, primary medical consultations and hospitalizations dropped by more than half, and vaccinations by 1/3 compared to 2013. In short, the whole health system collapsed. The shock waves of epidemics are always felt well beyond the devastated families and long after the last survivors leave treatment centers. In 2003, SARS caused losses of up to $59 billion, according to the Asian Development Bank. In 2009, the H1N1 pandemic wiped $2.8 billion of Mexico's tourism industry and led to a pork trade deficit of $27 billion. As a result of the Ebola outbreak, the International Monetary Fund reduced its growth projections for all of sub-Saharan Africa by 10%. Ebola also caused commodity prices to plummet and led to higher unemployment and fiscal deficits. Ebola taught us a valuable lesson. Global health security is only as strong as its weakest link. I repeat, global health security is only as strong as its weakest links. Let's put it in another way. No one is safe until we are all safe. This means all countries need to have resilient and robust local health systems to prevent, detect, and respond to public health emergencies at national level. We must support governments to build that capacity. Every month, WHO screens around 5,000 signals of new outbreaks across the world. We monitor this carefully because ignoring any one of them can be the difference between global spread of a deadly disease and rapid interruption of transmission. Every day, somewhere in the world, WHO is out in the field with local health officials investigating a potential outbreak. When an alert is sounded early enough, as when Ebola broke in the Democratic Republic of the Congo earlier this year, we can move quickly to support governments and stop the outbreak at its source. That outbreak in the Democratic Republic of Congo was contained in just a few weeks. Also, too frequently, the tragedy of war creates the perfect conditions for disease to spread. When health infrastructure is damaged or destroyed, when health workers are targeted and killed, when essential medicines cannot get through to the people who need them most, the world's defenses against epidemics start to crumble. It was no coincidence that Spanish flu, the greatest epidemic, erupted in the middle of what was then the greatest war the world had known. It was no coincidence that Ebola spread in countries that have suffered from years of war. It's no accident that cholera is sickening thousands in Yemen as we speak. Of course, epidemics are not the only threat to global health security. Natural disasters, biological and chemical attacks, food insecurity, and the effects of climate change all have the potential to put people's health at risk. That's especially true for antimicrobial resistance. The world's ability to respond to infectious diseases has been seriously undermined by its failure to ensure that medicines remain effective. Many common diseases have now become resistant to the drugs we have, and few replacements are in the pipeline. In fact, today we're launching a new report about the state of research and development for new treatments against some of the bacteria that pose the biggest threat to human health. It shows that the cupboard is disturbingly bare. We have nothing. Urgent investments in research and development are needed, but we also need new thinking about ways to incentivize our partners in the pharmaceutical industry to make those investments. But research and development is not a panacea. Action is needed across all sectors. For example, we're working closely with the camel industry to understand how MERS is crossing from animals into humans. We collaborate with the agriculture sector to detect, monitor, and respond to influenza viruses with pandemic potential. But at the same time, as we prepare for outbreaks and other health emergencies, we must address one of the most pervasive root causes of health insecurity, the lack of access of the most vulnerable people to essential health services. Without universal health coverage, there can be no global health security. They are two sides of the same coin. Universal health coverage is based on the moral conviction that health is a human right, that we refuse to accept a world in which people get sick and die simply because they are poor. It means, simply put, that everyone can get the health services they need, when and where they need them, without facing financial hardship. It sounds obvious, if only it was. But the reality is that more than 400 million people around the world lack access to essential health services. There are some people who argue that the estimate is actually more than 400 million. And at least 100 million people are pushed into poverty every single year because of the costs of paying for care out of their own pockets. It's important to emphasize that universal health coverage is more than universal health care. Yes, it includes care, but it also means that people can get care without risking financial ruin. After all, what good are health services if people don't use them because they can't afford them? But universal health coverage also goes beyond individual health services to those that promote health and prevent disease at the population level. Many of these do not even need health infrastructure or health workers to be effective, such as tobacco taxation and promoting healthy eating. A health system that's delivering universal health coverage also includes periodic services such as immunization and screening. A strong network of primary care clinics of everyday health needs, and the ability to provide more complex care in hospitals. When we describe health systems in these terms, our minds may immediately jump to the wealthy economies of Western Europe. But we should also think of countries such as China, Rwanda, Chile, Thailand, and Turkey, all of which have made giant strides both in improving access to health services and in making those services affordable for their people. Take China. In the past 20 years, China has made large investments in its health infrastructure, making health services more equally accessible to its vast population. The result has been large declines in child and maternal mortality, improved health outcomes, and increased life expectancy. In Rwanda, health system reforms over the past 15 years, including the provision of preventive services free of charge to the entire population, have also meant that more mothers survive childbirth and more children get to celebrate their 5th birthday. Rwanda's community-based health insurance scheme covers more than 80% of the population in a country where 90% of people work in the informal sector, actually. Here is the point. Far from being a luxury that only rich countries can afford, evidence and experience both show that universal health coverage is within reach for all countries, at all income levels. Every nation can do more with the resources it has. A recent WHO study shows that 85% of the costs of achieving the health targets in the SDGs can be met from domestic resources. Those investments would prevent 97 million premature deaths globally by 2030 and add as much as 8.4 years to life expectancy in some countries. Yes, some of the poorest countries will continue to need aid, but for the majority, universal health coverage is affordable and achievable. More than that, universal health coverage is politically smart, because just as epidemics can cripple an economy, universal health coverage can help it grow. Strong, resilient health systems are integral to strong, resilient economies. The logic is clear. When people are healthy, entire communities and nations thrive. When children survive to adulthood, they become productive members of society. When women survive childbirth, they can return to working or caring for their families. When communities are free from pollution, harmful products, and other causes of disease, they prosper. Simple, and everybody knows this. Too often, governments see the health sector as a cost to be contained, and this is wrong, rather than health as an investment to be nurtured. But the return on investment in health is very compelling. The world's top economists estimate that every single dollar spent on health yields up to $20 in full income growth within a generation. The health sector is also a growing source of jobs. Among OECD countries, employment in the health and social sectors grew by 48% between 2000 and 2014, while jobs in industry and agriculture declined. And because 70% of the global health workforce is female, jobs for health workers are jobs for women. All of this means that for most countries, the only real barrier is political will. The only real barrier is political will. Without exception, every country with universal health coverage or something close to it has got there because at some point in its history, its leaders acted with foresight, courage, and moral conviction. That is making a difference between countries, not resources. There is no single path to UHC. Every country must find its own way in the context of its own social, political, and economic circumstances. But the starting point is a determination to create a health system that on one hand protects individuals and families from incapacitating illness and financial catastrophe, and on the other guards against health threats that can hobble an entire economy. So what can we do? In my first week as Director General, I was honored to be invited by Chancellor Angela Merkel to address the G20 in Hamburg on this very topic of health security. I will tell you what I told them. First, we need to support countries to make progress towards universal health coverage by strengthening health systems, especially in the most fragile and vulnerable parts of the world and those in the grip of conflict. This is what WHO does all around the world every day. It's not always glamorous work, but it's extremely important. Second, we must prioritize research and development of new medical countermeasures through WHO's Research and Development Blueprint, which identifies the pathogens that are the most likely to spark an epidemic. Developing new vaccines and drugs is not the whole solution, but it's an important part of it. Third, it's vital that we map global capacities for emergency preparedness and response. Unless we know which countries have which capacities, it's impossible to deploy them quickly. When a fire starts, it's the wrong time to ask where the extinguishers are. And fourth, regular exercises are needed to stress test our plans, refine our processes, and check logistics. This is like a military drilling or simulation exercises, regular. Again, an epidemic is the wrong time to discover our preparations have been sufficient or that we have overlooked crucial components of the response. Finally, and fifth, we need to sustainably finance the global health security system to prevent, detect, and respond to threats. Governments must walk the talk to ensure a guaranteed level of contingency financing for health emergencies. Financing when there is panic doesn't help. I think we have to finance it during normal times and prepare for it. Delivering on these priorities will cost money, but only a fraction of what remaining unprepared will cost. Ladies and gentlemen, we do not know where or when the next global pandemic will occur, but we do know that it will exact a terrible toll, both on human life and on the global economy, and even may cause political instability. But we do not have to stand idly by and wait for disaster to strike. We can be prepared. Outbreaks are inevitable, but epidemics are preventable. This is not only a job for those of us in the health sector. Everyone has a role to play, from those who ensure the safety of our food to those who strive for safety in our world. Preventing conflict helps prevent disease too, and peace and security also is important. Guarding against epidemics and building resilient health systems requires determined souls and bright minds to prevent disease and to prevent conflict too. You know how our world is profoundly changing in a very negative way. For those reasons, I'm tremendously encouraged that a university with the stature of Colombia is launching a global health security and diplomacy program. What a fitting. and maybe a gift for me, to equip future health leaders with the knowledge and skills to solve the complex challenges we face. I wish you every success and look forward to working with you very closely. I thank you. Thank you very much.
Thank you very much to Dr. Tedros for his leadership at the WHO and his vision for advancing the goals of global health. My name, as you heard, is Walmar James, and I'm a South African Member of Parliament on leave to Columbia University to spend a year as a visiting professor in non-clinical pediatrics and international affairs. It is a novel joint appointment and ties together the field of international affairs with the business of medicine and public health. Before I invite our esteemed respondents to react to Dr. Tedros' address, it's my pleasure tonight to introduce you to the working group on health, security, and diplomacy, and the program that goes by the same name, that I'm honored to lead together with my colleague, Dr. Madeline Thompson from the Earth Institute at Columbia University. Since July, I've been working with colleagues in medicine, in public health, climate science, social science, and international affairs in putting together an interdisciplinary and intersectoral program in health, security, and diplomacy described in the brochure you will find on your seat. The purpose of the program, as this is a university, is to educate and train a new generation of health, security, and diplomacy researchers, professionals, and leaders in a context so well described by Columbia President Lee Bollinger and Dr. Tedros, by immersing them in the best available medical, public health, climate science, and diplomatic knowledge there is, and with a special focus on the needs and interests of children. It is a great opportunity for Columbia to build such a program at a time when the current administration in the US sends rather strong signals that it seeks to pull back from its global leadership role in health. Because the fact is that the world today faces both old and new risks to health. They are global in scope, to which all of us with resources and expertise must contribute to managing, because no single institution or government can do so on its own. It is and must be a shared responsibility driven by a single common purpose of advancing human health worldwide. Our program focuses on the medicine, the public health, the climate science, and diplomacy of health risk management is portrayed in the slide. It is with this introduction that I invite Dr. Jeffrey Sachs to respond to Dr. Tedros. Jeffrey Sachs, as you know, requires no introduction, but I will nevertheless point out that he is a professor of economics, he's a leader of development, and he is an author and columnist of note. He's the founder of the Earth Institute, the author of the Millennium Development Goals, and an advisor at the highest level to the United Nations and governments worldwide. I have asked him, as I have the other respondents, since I have to moderate the panel, and I want to allow for discussion and questions, which you may not know is by tradition only to be asked by students at the end. And so would you please welcome Dr. Jeff Sachs.
Welcome, and thanks we're in good hands, don't you agree? We're really in wonderful hands with Tedros at the helm of WHO. It's a crucial institution at a very complicated time, and I'm profoundly gratified that you have highlighted every one of the major challenges. We still have basic challenges of the most basic health in poor countries. Still 6 million kids are dying every year under the age of 5, overwhelmingly in very poor places, overwhelmingly of readily preventable and treatable diseases. So that's one kind of crisis that's very significant. We have, as you said, the emerging and re-emerging diseases. We've been battered now throughout human history, but especially in recent decades, by one new disease after another. Remember that AIDS itself is a zoonosis of a century ago that, because of the meager surveillance, was circulating in Africa, infecting millions and millions of people for an estimated 60 years, and was not determined until it was identified in San Francisco in 1981. That's a pretty pathetic and very tragic fact, because the zoonosis itself, the event that probably triggered the emergence of AIDS, took place somewhere in West Africa, probably around 1920. And this is how bad our surveillance is, but the risks are absolutely obvious. The irony of public health is it's such an incredibly good field. It's so capable, so smart, that you get an incredible amount for very, very little. You know, it's not a lot of money to save millions and millions of lives per year. And yet raising that little amount of money is sometimes unbelievably difficult. How big the fights were to get AIDS treatment started, how big the fights were to get some kind of organized malaria response, how big the fights are right now to help poor countries to deploy community health workers. I've been on this note together with my wife Sonia, who, as you know, leads a campaign for community health workers worldwide. And even in the middle of the Ebola epidemic, it was not possible to get coherent response from the international institutions. Pathetic, by the way, just absolutely pathetic. The World Bank, which I'm on an email exchange with today, just cannot put one foot in front of the next to actually get financing out. Global Fund, which I helped to start 17 years ago, and which Tedros chaired for a brilliant period, sometimes can't move, even when it's absolutely urgent to move. Then there are the complexities and challenges that are quite different from those of poverty, though they're spreading to poor countries. As you said, the food industry is killing us. And this is quite hard because the food industry is powerful. It is got vast lobbying, and it is an industry that produces obesogenic products that has made about 40% of adult Americans obese and addicted to just completely unhealthy things. And of course, the more you travel the world, the more you come back to the United States, you say, that is not food. What we see here, it is not food. It is organic, probably, mostly, but it is not food. And it's just horrible what's happening. And this is one of the great health threats that we face, but it's very political, just as tobacco is very political. Even when you know it, you can identify it. You know that sugar beverages are horrible for health and for mental well-being and for many other things. We can't move because modern capitalism. I always say I want to be in a business next time that has an addicted product, you know. You get lots of customers all the time, and this is how our system works, is build addictions, make large profits, hire lots of lobbyists, and sustain the addiction as long as possible, whether it's tobacco or soda or oil and gas and coal. It's basically the same model right now. So we also have a big problem of research and development that I just want to touch on briefly. The U.S. is incredibly productive right now, and world science is incredibly productive in new research, but we are going backwards on bringing the research to access. And as we've privatized research increasingly, and big private money goes into research, which is a tribute to our capital markets, we are producing more and more breakthrough drugs that are being priced at $100,000 a treatment dose, $300,000. Now the new cancer drugs are at $500,000 a treatment dose. This is really broken. We have a cure for hepatitis C, which is a wonderful drug, developed by a small biotech company with NIH support called Pharmacet. It was purchased by Gilead in 2011 for $11 billion. This chemical, sofosbuvir, it passed the final phase 3 trials, and then Gilead has been marketing it since 2012. The pills cost $1 to make. They charge $1,000 a pill. It's 7 weeks, 84 pills for a treatment dose. So for what costs $84 to manufacture, they're charging $84,000. Now, of course, there's some discounts. They always tell me, oh, it's only $40,000 if you take the discounts. So the strategy is that we have a system where there are 2 or 3 million Hep C infected people, and they're dying slowly of liver disease. And the government is the only provider, really, except for some high-cost private insurance. And the government says, well, you have to be pretty far gone before we're going to treat you. And so people are basically told, when you're near death, come back, and then you can get this drug. Now, if this drug were mass applied, we would actually end hepatitis C, because this is a full cure. This is not like HIV. This is a full cure. We could not only break transmission, we could end the disease. So this is a horrific misapplication of patent rights. Absolutely horrific. And I find it fascinating. When I write about it, I get lots of hate mail from Wall Street that says, what are you talking about? And I often I write back, people are dying. And serious people write back, so? I write, people are dying, large numbers. So that's how our system works, Professor Sachs. Get over it. And that really is a mental disease, because that is not a system that is producing results. And if we provide lots of wonderful new $500,000 treatments for cancers, that's not a system that is doing what it needs to do. So this is yet another challenge, because we're on an absolute scientific revolution right now, but we do not have a model of social justice to go along with the scientific revolution. So all of this is to say that you've got your hands full. We love you, and we want to help you. Thank you.
Thank you very much to Dr. Sachs. If I can now call on Beth Cameron, who is the Senior Director for Global Biological Policy and Programs at the Nuclear Threats Initiative. She previously served as a Senior Director for Global Health Security and Biodefense at the White House, at the National Security Council in the previous administration, where she was instrumental in launching the Global Health Security Agenda and worked in the following areas: in biosecurity, biodefense, emerging infectious diseases, dual-use research, and bioterrorism. Welcome, Beth.
Thank you very much, Dr. James. Thanks for inviting me, and thanks for hosting this event. And most importantly, Dr. Tedros, thank you for your leadership. What I'm going to speak about is a little bit about the future of the Global Health Security Agenda, which is it's just basically an organization of countries, non-governmental organization, sector, the private sector, and next-generation leaders that exist to support the WHO's effort to implement the international health regulations. And what you'll see is that everything I'm going to say just stresses and emphasizes what we've already heard from you tonight under your great leadership at WHO. So first and foremost, in global health security, WHO's leadership is essential. And not only WHO, but also the World Organization for Animal Health, OIE, and the Food and Agriculture Organization of the UN, FAO. And there's a great tripartite leadership that happens between those organizations, which is incredible to see and absolutely essential to the challenges that Dr. Tedros outlined. I don't have to convince this audience after hearing from Dr. Tedros that pandemics are critical, and I think the story that you told of the 1918 flu was absolutely the most poignant reflection of this issue. But I do think it's important, especially at an academic university, and for those of you in the audience who may not be in government, to think a little bit not only about health, but how health impacts security and national security. As a staffer in the White House, during the Ebola crisis, I saw firsthand what happens to heads of state in governments very far from affected countries who are having a hard time wrapping their head around what the Ebola outbreak in West Africa might mean for them. And there was absolutely a need for intellectual capital coming out of our universities, coming out of our civil society to inform the government in that situation. And so I'm so pleased to hear about the new center that's being launched here today. And I think that health diplomacy is going to be an absolutely vital field for the future. And I encourage some of the students in the audience to consider it. We need you, and WHO needs you. So the Global Health Security Agenda is a voluntary organization of countries that was launched actually after the first cases of Ebola occurred in Guinea, but before they were reported to WHO. And so this was put together in response to the fact that less than 20% of countries actually made the deadline for implementing the World Health Organization's international health regulations. And so the GHSA was launched in February of 2014 with the WHO, the FAO, the OIE, and a number of like-minded countries from all over the world with different backgrounds, different levels of development, and different kinds of health systems, with the idea that countries and sectors, so not just the health sector, but ministries of finance, ministries of foreign affairs, ministries of defense, needed to come together to talk about all of the different facets of global health security, from naturally occurring disease threats to lab accidents to bioterrorism. Countries were asked to make specific commitments. Those commitments were asked to be made and then reported back on over a period of time. And the goal there was really to raise attention to the level of heads of state, which has been very successful. As Dr. Tedros mentioned, the G20, the G7 have focused on this for the last couple of cycles, and that's something that I think is absolutely vital to be maintained. And I'm so happy that this is happening here during the UN General Assembly, because this is an issue that really needs to stay on the radar screen of heads of state, just like climate change, just like terrorism, just like other transnational threats. Also to incentivize accountability within governments for their own health system, but also accountability of those who say and make commitments that they're going to help others. How is that actually happening? How is it happening in country? And how are donors actually coordinating and tracking progress together more effectively? That's something that I consistently heard when I was an implementer working with and in countries, that it was very confusing often how the funding was actually being tracked and measured. And obviously, from your experience now and throughout your career, this is something I've heard from global health leaders across the board. So really important to be accountable. And then ultimately, the background of this slide is not just because it's a pretty color, it's actually the cover of a report that was put out earlier this year called the International Working Group on Pandemic Preparedness Financing. You heard from Dr. Tedros the absolute importance of financing health and health security. And this turns out to be a non-trivial feat. It's not just about asking for money, it's about sustaining capability over a long-term period, ultimately to break this cycle where we panic when we have an outbreak and spend lots of money, and then neglect the period where we don't have one, where those investments are actually less costly and more important. So the Global Health Security Agenda, in close partnership with the WHO, has made a number of different achievements, but the one that I just really quickly want to highlight, actually I'll highlight two. In green, the importance of metrics. And so through the Global Health Security Agenda, working with WHO, a set of targets have now been adopted for the international health regulations, which have been folded into the WHO external evaluations for IHR implementation. This process was critical, and if you had asked me when we launched GHSA if we would have gotten to this point, and I think if you'd asked most of my colleagues at WHO, they would have said no. Having peer assessments come into countries and looking at health security capacity and then publishing the results, it's never going to happen. But it has happened, and WHO now has a huge team under Peter Salama that has now done assessments in 50 countries, working with experts around the world, and that absolutely needs to continue, and I know is being strongly supported under Dr. Tedros' leadership. But GHSA has also become a platform for bringing in the private sector, for bringing in academic universities, for bringing in civil society. And I think that's a place where organizations like the center that's being launched here today at Columbia can play an absolutely critical role. How do you take specific goals in global health security, rally communities around them in a measurable way, and then actually monitor and evaluate the progress over time? That's one of the questions we asked when GHSA was launched, and it's a place where progress has been made, but a lot more progress, especially from the non-governmental sector, really does need to continue. I mentioned the joint external evaluations, and on the right side of the slide is just an example of what one of the evaluations results actually looks like. And I highlight this example because it's what most countries look like. There's a lot of yellow, a little bit of green, and some red. And the goal here is to turn all of that red and yellow into green, and to keep it green, and we can't do that unless we're actually actively evaluating and supporting countries to get prepared. So the last thing that I'll say quickly is I'll just highlight 3 challenges in global health security that I think the Global Health Security Agenda is focused on, but I know that also WHO is focused on as well. One is leveraging the commitments that are out there. So through the last couple of G7 and G20 cycles, many high-level commitments have been made. This is just one example, that the G7 has made a commitment to assist 76 countries and regions to implement the international health regulations. That's a fantastic commitment, but it's really hard to track down who's done what, for how long, and to measure the results. And I think that's another place where civil society can really help by measuring results, by looking at what's been done, and by helping keep countries on track for the commitments that they've made. Second, I mentioned accountability, and I think if you look at what the ultimate goal here is, there'll be an external evaluation in every country. Every country will have a national plan, and by every country, I don't just mean countries that have had more challenges with their health system. I mean every country. The United States went through a joint external evaluation when I was at the White House, and we found problems that needed to be fixed. Having a national plan, financing the national plan, having the political commitment to keep that financing going, and then ultimately continuing that effort by helping others to get prepared too. And so the non-governmental Global Health Security Agenda Consortium put out a call for the upcoming ministerial for GHSA, which will be held in Kampala, Uganda next month. And we asked, by 2019, could 75 countries realistically have a national plan based on the work WHO is doing? And could those national plans actually be financed? Could there be a sustainable financing strategy in place? This is a huge goal, and when we put it out there, a lot of people thought it might not be achievable. But I ask those of you in the audience and Dr. Tedros to consider this goal, because ultimately, if a country has a financed national plan, it's more likely that they'll actually be able to implement it, get prepared. And then finally, just to really emphasize, to foot stomp a point that Dr. Tedros made, which is looking at health security is really important in and of itself, but it's vital to look at health security in the broader context of health systems across the board and also universal health coverage. So these are issues that leaders have focused on over the last several years more and more under Dr. Tedros' leadership, and with continuing interest from countries around the world, universal health coverage is becoming an important issue. Global health security shouldn't compete with this. It should actually complement it. So being prepared for pandemic threats is part of your overall health system and part of access to care and services. And we saw how those things were intertwined very up close and personally during the Ebola outbreak. And so just urging those of you that work in this field to think about these not as competing priorities, but as three areas that actually all need to get attention and focus. And I'll just stop there and say that I'm incredibly pleased to be here, and thank you again. And thank you, Dr. Tedros, for coming.
I must say that the panelists are extremely disciplined. Thank you very much, Beth, for your contribution. The final respondent is Dr. Gavin Schmidt, who's a climate scientist and director of NASA's Goddard Institute for Space Studies, and he's a senior adjunct researcher at the Earth Institute. He works on understanding the drivers of climate change. He was the inaugural winner of the AGU Climate Communication Prize in 2011, the Earth Sky Science Communicator of the Year, and his 2010 TED Talk has been seen by more than 1 million people. Thank you for coming, Dr. Schmidt.
Thank you very much, honored panelists, respected guests. So I'm going to talk a little bit about climate change and the impact that that has on human health and well-being. NASA is one of the lead agencies that monitors climate change, that studies the processes that underlie our understanding of how the climate system and the Earth system works, that builds the models that are used both to go back into the past and understand why things have changed before and why they are changing now. Climate change is often thought of as a purely physical phenomena. Changes in the temperature, in the rainfall, in the winds, in the storms. But at its heart, climate change is a human problem, because all of those things do not occur in a vacuum. They do not occur on a planet where there is no society, where there is no infrastructure. Our concerns about climate change are associated not just with the intellectual pursuit of understanding, but with the very real impacts that climate changes have on people, societies, and ecosystems. Now, when it comes to human health, the impacts of climate change range from the obvious and perhaps not that serious to the indirect and perhaps devastating. We can all think of what happens to human health in places where there are greater numbers of heat waves. You know, people who suffer through heat, and I mean, there was a classic example in Europe in 2003, where tens of thousands of people died prematurely because of a heat wave and an insufficient amount of preparation air conditioning, and looking after people. We can see people drown when there are flooding events. We can see people injured by strong winds. I mean, this last month has been a catalogue of direct weather, perhaps climate-impacted events taking their toll directly on human health. But I think the more worrying and the more concerning aspects are the indirect ones. What happens to infrastructure when there are increases in intense precipitation? What happens to infrastructure when there are increasing numbers of heat waves? What happens to societies and systems and utilities and power lines and sewage systems when there are large flooding events? Those are the kinds of indirect impacts that lead directly to health consequences. One of the biggest problems in Miami-Dade County, is the fact that when there is flooding, there's an enormous amount of sewage that's kept in septic tanks because most of the houses are not connected to proper sewage lines. So when the waters flood and the waters rise, it's not water, it's sewage. In Houston, when the waters rose, they flooded chemical plants, and again, producing slicks of not water, but toxic pollutants. These have very direct health impacts on local populations. There are other aspects. There are disease vectors, there are pests, there are parasites whose life cycles depend on certain aspects of the climate. The temperature, whether it gets cold during the winter or not, is a big factor in the pine bark beetle outbreak, again, which is leading to increased risk of fire, again, another health impact. So the indirect impacts of climate change on systems that are perhaps already stressed by many other stressors are going to be, and this is a prediction, are going to be the biggest impacts. Now, our ability to assess the costs and the damages associated with these indirect impacts of climate change is at its infancy. There's great work being done at this university and at others on trying to link these things together and to try and get estimates of these indirect costs, but it is still very, very much a work in progress, and one, hopefully, that the new institute will be able to address more thoroughly than has been done before. But we can also step back a little bit. What are the causes of climate change? What are we actually doing to create climate change? We're burning fossil fuels and we're deforesting. Those actions have in themselves other indirect health impacts. When you burn fossil fuels in internal combustion engines, you produce NOx, you produce smog, you produce greater numbers of bronchial problems, asthma, and associated issues with air pollution. When you increase the amount of carbon dioxide in the air, you increase the acidity of the ocean, affecting communities and ecosystems all across the surface ocean. When we change how we practice agriculture and we increase the amount of nitrates in the system, that goes into the waterways. It impacts algae, it impacts blooms, and it impacts, again, human health. When we're looking forward and we're seeing what our choices are as societies to mitigate, to adapt, we have to be able to put all of these things together to assess not just what the climate impacts will be and the direct and indirect impacts of the climate, but also what the direct impacts of the actions that we're taking will have. We've done analyses for the UN Environmental Programme that demonstrate very, very cheap measures to reduce black carbon, methane emissions can have enormous benefits, not just for climate, not just for air pollution, but for human health and for the economy directly, even if you don't include all of those indirect climate effects that I mentioned earlier. But again, we are at the beginning of thinking in a joined-up way about all of these different things. Climate is one stressor that is adding to others: inequality, war, economic collapse. And it is not necessarily the only driver or the single cause of many of the problems that we are going to see. But it is going to be increasingly one of the key and important elements in those events. And so when we're doing that preparation, when we're stress testing our systems, we need to be factoring in the sea level rise, we need to be factoring in the flooding, we need to be factoring in the changes in disease vectors and the impacts that it has on emissions at the same time. This is a huge, huge challenge, both intellectually and societally. Jeff mentioned how difficult it can be when you have situations or topics that are heavily politicized. Climate change is one of those topics. But that should redouble our enthusiasm and our promise to do a better job on incorporating all of these factors into the global health agenda going forward. Thank you very much.
Thank you very much to Dr. Schmidt. And ladies and gentlemen, this is what we'll do now. I'll start the discussion, and we will have panelists respond to some questions that I'll begin with. And we will leave some time for, depending on how much time we have, but we should take at least 3 questions from the floor towards the end, and we will close at 6:30 promptly. And so if I may just begin by saying the following, that the United States spends $14 billion on global health. That's excluding on itself. The UK spends $4 billion, and the budget of the WHO is between 1.9 and 2 billion. Most of the world depends on the WHO for health in response to emergencies. And with the amount of money that the WHO has, it is, I'm sure, severely stretched in many ways. And so the question that I'd like to pose firstly to Dr. Tedros is, in which ways will he increase the revenue flow from member states in terms of their fees and in terms of voluntary contributions for programs, and how in this new world of public-private partnerships, what smart ways there are that he has, I'm sure, in mind in forging collaborations with a whole range of players in the global health area. I'd like to draw on Dr. Sachs to respond to the question of financing as well. But simply to pose the question, what is his view? What are his approaches? What are the new ideas in terms of generating more revenue for the WHO to do its work?
Yeah, thank you. I think the financing will depend on whether member states believe that WHO is still relevant or not. And I think from many of the meetings, and today in the presentation also, WHO's relevance, nobody actually questions it. For our global health security, a multilateral organization like WHO is very important. So everybody underlines. Then if that's true, it starts from there. Then you have to resource it. Simple. Because if you believe that this organization is yours, then you have to commit to pay for its activities. And there are some things we're putting together now in order to address the financial problems, not only asking from member states, but also some things internally. Number one, I think prioritization is important. That creates value for money. So WHO should be able to prioritize what it does and focus on major, important, and high-impact issues. That's one. Number two, in addition to the traditional donors, expanding the donor base is important. And we have already seen signs that some countries are willing to contribute. Number three, even with the existing donors, the funding should be flexible funding. Sometimes you have some money earmarked for something, but you have shortages for other things. That's a priority actually for the organization. And WHO should own its own business and should be trusted by the member states. So basket funding or flexible funding is very important. But in addition to that, we need to move into new mechanisms also, innovative financing. You said private sector. Private sector is key. We have to involve private sector as a source of financing also. Of course, it shouldn't be in a way that affects the normative functions, because the normative functions should also be firewalled. So there should be a balance. That's something that we have seen. Maybe you can give me some feedback is the innovative financing could increase actually more resources to WHO. One area is WHO is a knowledge-based, so how can we use ICT? I have met with Facebook and GSMA, and they're willing to help in using those platforms, be it mobile or the Facebook, Google, in order to raise funding for WHO. You may not believe it. For instance, our colleague was saying panic and neglect. And during panic, a lot of money comes because that's during actual epidemics. But as soon as that's gone, there is neglect. And from the contingency fund we need for WHO, $100 million US, there is a deficit of more than 50%. So it's really sad. So there should be a flexible and sustainable financing, and that we believe should include the new financing mechanisms, innovative ones, that should be sustainable and flexible too. So we're exploring all the avenues, but including the member states, which we expect should increase both assist and voluntary contributions. Then the last part on financing is there is a finance dialogue with member states to raise funding. That model doesn't work because it puts WHO on one hand, on one side, and members on the other side, WHO begging and the member states as donors. But WHO's objectives are member states' objectives. So there is no us and them, there is us. So member states should take responsibility in raising funds. So the model should change. That's one thing that we're underlining, and member states are considering this seriously. The second is, when we discuss about raising funds for WHO, instead of starting from financing WHO, we should start from discussing about financing global health agenda, the big envelope itself. Within that, what's needed for WHO is just a subset. So into our resource mobilization, we're bringing these two major shifts. One, it's not us and them, it's us. So member states have the obligation to raise the funding. And two, when we raise the funding, we have to raise enough funding for the big envelope, which is resources enough for the global health agenda and within that, resourcing WHO based on its needs. So based on these shifts, we have already started dialogue with the member states, and we're seeing some good signs, and we will push in that direction. But I would be happy to listen to what Jeff says, and he's already helping me. So he knows this better. It's his territory, and he promised to continue to help WHO, and that means Global Health Agenda. And I'm really glad that I have a partner here in Colombia and help. Thank you.
Yeah, thank you very much for that. Could Dr. Sachs, in your response, could you also address the question of children and the Millennium Development Goals around child health and the relationship between UNICEF, which is responsible for child health, and the WHO in responding to the question of financing?
Almost everything that's said about financing in the public debate is confusion. We had it when Trump yesterday said how the UN is bloated and we're going to need to see cuts and so forth. The U.S. contribution to the UN, to the basic budget, is $600 million a year. That's 7.5 hours of Pentagon spending. So there's nothing bloated. We're starving the international system. It's not a bloated system. We're starving it. The thing that we're not starving is this military machine, where the Senate yesterday disgracefully voted a $700 billion budget, even more than Trump asked for. And to go beyond Trump, you have to really be crazy, I'm afraid. So this is the first point. We don't use our wealth at all sanely, and not as people think, and not as we need to do. So we underinvest incredibly in this. A second point that is taken for given is each country should look after itself. This is pressed all the time. This is bogus. We should look after each other. And we need to break this Ayn Rand hold, which comes from this country. She's a lousy novelist that is confused for a philosopher only in America. Do you want a philosopher? Go read Aristotle, okay? Ayn Rand is poor fiction. But this idea, you're on your own, really permeates the global discourse. And even in your charts, there wasn't poverty there. Every country's supposed to have their plan. Well, some countries can have their plan. I looked at the countries. I know those countries. They don't have a budget to do this stuff. But if I go to OMB, even under the Obama administration, it was impossible to get this stuff. So we have to be realistic, always looking at what our needs and what the budgets are. And we have to break the myth that this should be left to the private sector. I went to Facebook a couple of years ago. I said, I want help on global education. They said, why are you coming here? You go to Washington. We're a business. I was okay. I said, you pay your taxes, I'll go to Washington. And then I was thrown out of the building. We've got a game going on. These companies don't pay their taxes. They're all in their tax hideaways, which, by the way, now they're going to have to visit their money some other place because they've all been destroyed by the hurricanes, which is where the hedge fund industry resides. So I don't know what they're going to do to visit their money this week. And we don't have the public revenues. And we have a myth also that the government should not be the one to do things. It's not efficient. But if you look at the great scientific breakthroughs that have come for the last 75 years, They have come in government work, thank you. Whether it's in NASA, well represented here, whether it's in DARPA, we get a lot of great innovation out of the Defense Department because that's the one place that we invest our public money. Fortunately, they do some civilian work as well. National Institutes of Health. And so we should be putting a lot of money into WHO to help oversee an R&D agenda. But this is almost unimaginable right now. So the truth is, and I'll just stop here, we're so rich you cannot really believe it until you walk in Midtown, especially on the east side, then you know it. Because things are booming here. There's so much wealth you can't even imagine. The restaurants are packed. I wonder how many hundreds that you see. How do they pay these meals? Because there's a lot of wealth, but no one's paying their taxes right now. And the taxes, if they are paid, are going to the military. And then we're hearing this rot like we hear from the president, who's a very confused person anyway, but someone gave him something to say that says the UN is bloated. It turns out, apparently, just his golf trips are going to cost the taxpayers more than $60 million a year, maybe well more than $60 million. By one estimate, more than $100 million a year. So that's a good place to start also for innovative financing. Donald Trump could pay for his own golf trips, and maybe the U.S. government could pay for WHO. But my other advice would be, seriously, the U.S. is now the drag on the whole international system. It says no to all finance, and then it says to others, you don't pay either because we're X share. We don't want to lose our veto. We don't want to lose this. So it tries to hold everybody to minimum right now. I'm looking forward to the day when China is going to amply fund these institutions. India is going to amply fund these institutions. Other countries are going to amply fund these institutions. If the United States doesn't want to do it, everybody will know, okay, we'll all survive. It's not such a big deal because there's a whole rest of the world, but the U.S. should not let what is absolutely necessary hold back the rest of the world now. We can't, this craziness that's coming from this country cannot be the limiting factor for the financing we need. So there.
We must certainly thank Dr. Sachs for his leadership on these issues. If I can turn to Dr. Cameron and just ask the following question. The global health security agenda was financed through an emergency congressional appropriation of $1 billion, and it is going to run out next year. And so the question is, what is the appetite in the current political environment for replenishing that? So I'd like to ask her that question. And just as a side question to the issue of financing and the role of the U.S. military in medicine, the U.S. military plays a huge role and very positive role in terms of some of the discovery science and vaccine development. If you think of what they do at Walter Reed Institute, quite extraordinary work in the area of disease detection as well, globally and so on. And the issue politically is how one leverages that. And so I'm asking the question, what is your view of how to leverage that side of the funding without compromising spending on health as a public good? Because it's often the criticism that health security has dominated by military involvement, focuses much more on the security side rather than the public side in terms of health.
Thanks. Thank you. Those are both great questions, and I'm happy to answer them. So I think in terms of the U.S. government funding, to take the first question first, so the U.S. government received approximately $1 billion for global health security in the middle of the Ebola outbreak. And that was pretty extraordinary, to be honest with you, because it was forward-thinking. It was looking at the future while we were in the middle of a crisis. And so it was really hard to get that funding out of a Republican Congress, I will tell you, but they provided it. The critical point with that funding, though, was that it was tied to specific metrics that needed to be achieved by the funders in collaboration with the governments. I don't mean to imply that all of those metrics were on the countries. They were also on our own spending to make sure that we understood what we were doing and that it would actually help build sustainable capacity that would help implement the IHR. And that was essential. The Office of Management and Budget looked at the Global Health Security Agenda and its targets that had been built before the funding came in, and made the decision to ask for that funding because they knew that it could be measured, because there were some targets that had been achieved, and because WHO and others were already at the table. So that was essential. I think that in order to maintain funding for global health security in the current climate, and I will say that the Trump administration has supported this issue rhetorically. They've said they support global health security and the global health security agenda. I think in order to see funding for this, there has to be an extraordinary effort to advocate for it and for Congress to provide it, and to be able to show that it is a common good that is essential for global peace and security and U.S. national security. I think those arguments can be made, but I think that the funding needs to come in for CDC and USAID and the budgets that are already out there for Department of Defense and state to be at the table, and global health security need to be maintained, because the multi-sectoral budget that we have helps bring multiple sectors to the table in other countries, and that's very helpful when you're having financing conversations and when you're trying to look at measurable goals. I'll take this opportunity, though, to quickly respond to what Dr. Sachs said as well. I completely agree with you that not all countries can do this on their own, and absolutely shouldn't. But I do think that every country that has a government, recognizing there are countries and populations in the world that don't have that luxury at the moment, can look at the planning that's been put in place. And WHO has worked in places all over the world, including countries that absolutely can't finance this for themselves, like Burkina Faso, to put together a health security plan. And the health security plan is tailored to their priorities and needs, and that's vital. And I think that that's helpful in bringing sectors of government in places that otherwise wouldn't be able to focus on this issue, but providing them that help and support. And that's a place where WHO and its local leadership has been absolutely essential. And so when we look at supporting WHO, which is critical, we should be looking not only at support in Geneva, and not to imply that you said that at all, but we should be looking at supporting the WHO local offices and the experts that are on the ground working there, and also supporting how they plug in to the broader donor effort, because they can't do it alone either. They do need the donor governments to help, but we need them there as well to be the glue. And then quickly to respond to your question on military and Department of Defense, in particular involvement. So one of the roles that I've played in the U.S. government was in overseeing U.S. funding through DoD for biological threat reduction, which focuses on biosurveillance, biosecurity. I also worked closely with the defense health programs that have laboratories all over the world, some of which have been standing in places like Cairo and Thailand and Kenya for more than 50 years. And the way that those programs are most successful is when they are integrated into the fabric of the societies in which they work. And so in Cairo, when I would visit Egypt, the WHO office for EMRO, the national, our overseas laboratory, Naval Medical Research Unit, NAMRU 3, and our own U.S. government programs worked hand in glove. And so in some situations that I was in, people would say, I'm really worried about the Department of Defense involvement, but I welcome NAMRU 3. And that's where you want to be. You want to be in a situation where those experts are part of the fabric, working with WHO, working with the host governments. It's really, really important that we continue our investment in those areas, but that we do it not at the expense of lines for Centers for Disease Control that we don't do it at the expense of USAID or the WHO. But we need them. Right now, most of the U.S. government spending for global health security, including in places like Liberia, where the Department of Defense is helping build a central reference lab with that government, that funding is from the Department of Defense. I'm not saying that's the way that it absolutely should be, but it's really important. It's helpful in building safe and secure facilities, and it's helpful because it is at least funding, and we need it.
Thank you very much. I'd like to turn to Dr. Schmidt on the question of climate change and climate information and environmental information, and some of the practical things beyond what it is he described in a second, but by focusing on what's been often described as market failure in the delivery of vaccines and medical countermeasures when it's needed. It's particularly true during emergencies and catastrophes. And I'd like us to remember that it's not just pandemic infectious diseases, but it's also accidental chemical spillages or deliberate or biological spillovers. Some are deliberate, radiological and so on. It's a whole range of threats, of health threats. And they all require a degree of hospital readiness in order to cope with it. And they require, very importantly, the delivery of vaccines, of course, which prevents an infection from taking hold, and medical therapies to deal with disease once it's broken out. And so to start off with you, Dr. Schmidt, can you tell us what would be helpful to know about climate in order for people who deliver vaccines, for example, globally? So it's a logistical question. What it is they should know about climate variability that would allow them to plan far more effectively, especially when you're dealing with emergencies.
Well, okay, that's a little bit outside of my wheelhouse. Let me see if I can say something intelligent. One of the problems that exists in delivery of vaccines and other medicine to the more far-flung and less connected parts of the world is that we don't actually even have good weather forecasts for these places because we don't have enough in situ on-the-ground measurements of temperature and rainfall and the winds that would be able to feed into the global models that produce the forecasts that can be useful. And so our ability even to forecast the weather in places like Central Africa is much poorer than our ability to forecast the weather in the US or in Europe. Those are things that can be fixed with, increasing investment in automated weather stations. There was a project with Ericsson that Columbia worked with to put automatic weather stations on cell phone towers, so that as the cell phone towers reached further in, then more information would be coming back as well. I don't think that the kind of more long-term projections that we're working on, at the 20, 30, 40-year level are really of particular help in, immediate logistical issues. But the whole notion that you need to be thinking about the environment in which you're going and being able to track what's going to be happening there, when it's going to happen, even in the short term, is obviously something that we work quite a lot on. How'd I do?
Okay, no, thank you very much for that. I mean, it's a general problem, right? So there is market failure in terms of getting vaccines to the right place at the right time. But there's a bigger question that was raised by Dr. Tedros in terms of having a pipeline of medical therapies available that is proactive. And the WHO has a whole long list of what is the most likely outbreaks that would occur in the area of infectious diseases. And so you can go into the website, as you know, to see that. You mentioned it in your talk. How do you see stimulating research and development when it comes to vaccine development? And so it's an R&D process, and there has to be a pipeline that's available to produce those vaccines. I mean, what is the perspective on the part of the WHO to help with that process?
No, on vaccines and research, I think it will be important, first of all, for those with public health importance, governments should invest. Governments should be willing to invest. Because there are market failures where the private sector will never go into that territory. So that's one. And the second, for those that have some interest in the private sector, I think the advanced market commitment that Gavi is doing would be important. So a combination of the two. So governments plus the advanced market commitments for the private sector. This will really help. By the way, on the drugs for hepatitis C, one area is generic. So we're doing that, and $120 US. So that will help, and we can go to elimination now.
Just not in the U.S.
Not in the So in addition to generic, I think building the manufacturing capacity of countries is important, especially in the developing world. And as you know, under the Go Global program, many manufacturing industries are migrating out of China. And that's very good opportunity with the increasing wage in China, some industries migrating towards the developing world. And that could be used to increase the manufacturing capacity of the developing world. Industrialization can come with that, and industrialization, as you know, means innovation too. So I think using those opportunities will be important. So that could be applied for drugs, that could be applied for vaccines. As we know, many of the expensive medicines or vaccines, at the end of the day, the issue is the supply and demand issue. So if there is, if we increase supply, then the price could be lowered. And that's why increasing the manufacturing industry of the developing world could increase competition, can bring competition, and that can help. So long term, I think we have to consider those. Of course, there was a high-level panel recommendation last year, and there are some recommendations made by the high level, but these are some of the strategic solutions that we need to take. May I comment on the climate change?
Of course.
On climate change and health, that's one of the pillars actually in my priority when I was campaigning for this position. On climate change and health, maybe I would like to raise two issues. One, WHO is focused mainly on adaptation. That's wrong. Of course, it should work on adaptation, but it should do more on mitigation. The health impacts of increased carbon release, I think, and its impact on health, WHO should really raise the alarm. So more advocacy and very vocal one on mitigation, because mitigation is prevention, and WHO is for prevention. So we cannot just be on adaptation and only, fix the problems as they arise, which we cannot fix anyway. And climate change is a serious problem. It's a problem for the whole world. But at the same time, although it's a problem for the whole world and all countries, but there are countries that are more affected, disproportionately affected than others. So we need to help those with a sense of urgency. And these are the SEEDs, the small island developing states. And they have to be supported. In WHO, we're starting a new initiative, SEEDs, Climate Change and Health Initiative. And we will give them more support because they are disproportionately affected. And that initiative will have programs and projects that will come from the SEEDs themselves. No one should prescribe to what to do. They should be the ones who should tell us how we can help them, and we can facilitate and help them. So this is one of the initiatives we're going to work on, and Columbia University, I know, will help in making this succeed. But we have to really help those who are really disproportionately affected. Thank you.
So I just like to just stick for a minute on the question of vaccines. You may have noticed that Sanofi Pasteur withdrew the development of the clinical trials, in fact, for 2 vaccines for Zika. And what they said was there were 2 reasons. One was the epidemiology of Zika, and the second was the erratic statements by the Trump administration. Because the whole question of the production of vaccines has been a boom and bust business. So when there's a crisis, there's a lot of effort, a lot of money put into it, and when it ebbs, there's a decline. So, and so it is a risky investment. So the question is, how do we get a far more stable funding in the vaccine business? And I raised it as an issue, and I thought that as part of your response, Jeff, you might be able to comment on that too.
I think it's interesting to think about another vaccine case half century ago, 60 years ago, which was the polio epidemic. And there, actually, Franklin Roosevelt created what became called the March of Dimes. The March of Dimes funded Jonas Salk, his research at University of Pittsburgh. When he came up with the vaccine, he was asked famously, so who owns the vaccine? Who owns the patent? And he said, the public, of course. He said, could you patent the sun? You know, well, that's a wonderful sentiment. The vaccine was made public. It went to rapid application. The epidemic was ended in the high-income countries. Now we're on the verge of full eradication. But the point is that it's a different intellectual property development model, obviously, the public channel. And because of the challenges of vaccines, there are tremendous public goods aspects, and they're for very poor people, and the market risks and the fluctuations. There should be a massive public effort for development of vaccines and their propagation. We have Gavi. There can be a research arm that's attached to Gavi as a mechanism of this. I wanted to say another word about the climate issue and aid. We talk about aid for hard-hit countries, but if this were a court of law, those countries would have claims, damages for what in law would be called the public nuisance, that their right to their land has been damaged by outside tortious interference, in this case by the rich countries. So we have an obligation to pay. We call it, under the Paris Climate Agreement, losses and damages, which is a category. But when the rich countries negotiated that, they said this is not compensation. But of course it's compensation, should be compensation, because the overwhelming responsibility for the climate change is not the small island developing states or the Sahel or the Horn of Africa or the Caribbean and others. It is the rich countries. You can even find the companies involved, because Exxon and Chevron are at the top of the list of historical responsibility. So they should be nabbed directly in court for their responsibility. So we have to change the language. And again, it comes back to this idea that somehow we think that we're immune to responsibility, but we have to actually be held to account for the responsibility. So I want to put aid not as the relevant category here. I want to put accountability and compensation as the relevant category.
Thank you very much. I just got a note to say that Dr. Tedros has another engagement and he has to leave, like right now. So I was hoping to get at least 2 questions from students. And I'm going to ask you to please come to the microphone.
So I'll introduce myself very quickly. I also have a question, a follow-up question for Professor Sachs. Can I maybe ask that after Dr. Tedros leaves?
Yes, if you can put the question quickly.
Okay. So thank you so much for being here. I actually used to be at the United Nations. I was a former advisor to the Group of Friends for Gender Parity. So we're almost over 100 countries now who are advocating for a gender equal leadership of the UN Secretariat. And it was in my conversations with one of your predecessors, Gro Harlem Brundtland, which is the reason why I'm here now and pursuing a degree in medicine, first as a post-bac pre-med student. And so my question is, with this growing pattern of isolationism worldwide and with the lack of funding that we've talked about a lot, there are major gaps in the global health agenda, and where exactly the private sector can fill in those gaps, not just in terms of raising funds and financing certain aspects of it, but in terms of the R&D process, or maybe donating certain drugs that are in need in certain places, which is difficult, and then leads into my second question to Professor Sachs.
Do you mind holding on your second question?
Okay, sure.
I'm going to ask Dr. Tedros to respond. We have to be fair here. Unfortunately, he does have to leave. I'm going to ask him to respond to that. And I'm afraid there won't be any further questions to Dr. Tedros.
And just how you can incentivize the private sector.
And you thought you just sneak that in, right?
No. This isn't the question. Just to complete the question to Dr. Tedros, how you can incentivize the private sector to be involved and take ownership in this global health agenda.
Thank you.
Yeah, so I can take one, two, or one by one.
Well,
You're giving me only one. Okay.
I'm just giving you that one, yes.
Okay. No, thank you. But it has actually two questions. I think you raised the gender parity issue, and then I don't know why you forgot it. I thought that was the question. Anyway, I can reframe it like a question. I mean, are you going to do gender parity in your top leadership?
No, my question is to clarify. There are major gaps, not just financing and funding in the global health agenda, and how the private sector can fill in those gaps that you could identify, and then also how you can incentivize the private sector to take ownership in the global health agenda and be a part of the solution.
By the way, one of the opportunities we have is the FENSA. It's a framework to engage the private non-state actors, private sector being one. So we have that framework that was endorsed last year. So based on that, that opens up opportunities to engage the non-state actors, and we will try to benefit from their contribution. But we have to, I think one thing I need to admit is WHO is a bit afraid of engaging the private sector. I think that's what you're up to. And we shouldn't really be worried by that. There shouldn't be even any condition to engage the private sector. We know where the conflicts of interest may arise. We should be conscious about that. But there shouldn't be fear in engaging the private sector. So it all starts from there. We have to change the mindset. And we have to believe that we can work with the private sector while still safeguarding the areas that should be safeguarded, or really managing the conflict of interest. To do that, for the private sector, we need to have a clear strategy based on the priorities that we have to seek their engagement. First, we should know our priorities, and then sit down and discuss on these priorities. And the engagement should not be at the global level only. It should go up to country level on how the partnerships could really benefit the global health agenda, which is a priority for all of us, including the private sector. So this is the framework we're trying to follow. And I have already spoken to some of them. In the last 79 days, I have started my new post. And the engagement I had was very, very candid. We had a very candid discussion. it all starts there. We need to be honest with each other. So we will involve them in many of the major issues that we have, and we will need their support. It shouldn't depend, as you rightly say, just finance only. Many areas where we can really partner. But our partnership should be based on trust and also very candid discussions and honest relationship and genuine partnership. Thank you.
So on that note, thank you very much, Dr. Tedros. We now have to release Dr. Tedros. As a former politician, understand what exactly this means. And so we have to do that. I'd like to thank him for coming here to talk to us. And to say that, as he's walking out, that it's very of the greatest importance that we support the work of the WHO. It is the only global body with universal legitimacy, and anybody who wants to do any work anywhere in the world requires diplomatic cover from the WHO. And therefore, it's really quite important for us to support him in his work. So we started late, and with your indulgence, I'm going to run till 25 to 7 to give the students a chance to put questions. And so if I can ask you, please, to put your question as crisply as you can.
Okay. Hello, my name is Luke Nelson. I'm a student here at the college. I'm a junior student studying psychology. Last summer, I was an IFAB fellow, one of few undergraduate students who got the chance to go to Haiti and study maternal health care and accessibility to maternal health care. And I had the chance to like retrain community healthcare workers and just sort of provide quality control on sort of the work that they do. However, one thing that I did notice was a sense of discouragement and a sense of sadness surrounding their issues and sort of tiredness in terms of the efforts and the work that they actually do. So I guess my question more specifically is, within the global discourse and with Haiti's economic dependence on emergency funding and sort of the lowering of funding throughout the years by organizations like the USAID and other private sector funders, what goes into sort of ranking and sort of understanding which countries take priority in terms of the help and the sort of the work that is needed to be done within said country, but also I guess, like, has the term global health security been adopted to encourage countries who can spearhead these initiatives? Or more so, like, how do you motivate these 70-plus countries given all of the unique circumstances that all of them do face?
Okay, thank you very much for that question. If you can just hold the response, I'll take the next person as well.
Hi, my name is Elena. I'm a postbac student at Columbia, and I had a question for Professor Sachs. So, as you described, the U.S.'s formidable food industry system hurts us and overall population health. So, I wanted to know what you thought would be effective and specific ways to respond to this. The food industry system and how it hurts us. Is the mic on?
Food. Oh, sorry. Okay, I didn't hear food. That's what I was missing. I missed that word. Okay.
Critical.
But I am getting hungry. Okay.
If you can deal with that question, Dr. Saxon, if on the question of Haiti, if Dr. Cameron can respond to that in terms of the global health security agenda. Go ahead.
I wanted to say something about Haiti too. Just
that's fine. Go ahead.
Yeah. Just very, very, very quickly. There are two kinds of answers to the question. One is a kind of formal textbook answer of which countries are on which lists, who needs help, and so forth. Then there's the real answer, which is geopolitics. We don't care about Haiti, period, except if there is some kind of refugee movement or if we want to overthrow their government. And so if you actually look at how Haiti got into this unbelievably weird situation that it has been in, of course there are many things going on, but if you go back to, say, the early 90s, Aristide was overthrown. Okay, then the U.S. put Aristide back in, and then the U.S. said, but you can't really stay in. So Clinton put him back in, but said you have to leave right away, so then they put in Preval. And then Aristide came back, and then George W. Bush said, I want to take out that guy. So they tried to break Aristide's government for 5 years between 2001 and 2004. Then they sent in the CIA, and they overthrew him. And they put him in a plane and carried him for 23 hours to Central African Republic. And if you check, the New York Times would not report that, because they're in bed with the CIA often. So we couldn't even get a straight story of a guy deposed in broad daylight in our own hemisphere. And then, okay, they put in another one, and then massive hurricanes, then massive earthquake, then mismanagement, then Bill Clinton in charge, nothing recovered. It's unbelievable. That's called geopolitics. It's, we broke the country's economy by repeated boycotts, solved nothing, and there's some national responsibility along the way, but basically we were obsessed, especially the Republicans were obsessed with Aristide for 20 years, and he was the only popular politician in the country. And so if you have the only popular politician, you have to keep overthrowing him. You don't really create a base for legitimate action. So this is the real story. On food, look, we first of all should say really what's going on, and I'll give you an example. Last year, the top nutritionists in this country wrote a chapter of their advisory report that showed that a healthy environmental food production system would also lead to a healthier diet, and that would be less beef, because beef is both destructive environmentally and it's bad for the health, the amount that Americans are eating it. Well, the Obama Secretary of Agriculture, Tom Vilsack, excised Chapter 8 of the USDA, said that's beyond the recommendation boundaries, because the food industry apparently is important as lobbyists, and they didn't want to have a chapter that spoke straightforwardly about these risks. We know the beverage industry, we know the beef. We were able to take on trans fats because the nutritionists led a real campaign on that, and the companies were able to find something different. But basically, there are a handful of large companies here that have a tremendous culpability in the obesity epidemic, and they need to be held to account, and they need to come up with a plan for phasing out their terribly dangerous products. And we're the only country, if you look on the charts, well, we're not the only country. They're spreading it now to very poor countries that don't have defenses. But we are so much above the obesity rates of other high-income countries because we're so much more vulnerable to this kind of lobbying.
Thank you very much. Do you want to make a comment on Haiti?
Sure. I'll be quick and just say that I'll say two things. One, Haiti was prioritized as part of the U.S. government commitment to assist at least 30 countries, and through that prioritization, they are developing a national plan with a lot of assistance, rightly so, from CDC and USAID. And so that's important. It's a step forward, but obviously there's a lot of work to do. The second comment I'll make is just that there isn't, to get to the heart of, one of the hearts of your question, I think, which was a great question. I don't think there is currently a reliable way to know how countries fit with one another, how they rank in terms of their health security, and how that fits with their overall health system. One of the projects that we've been working on in pilot since I've been at NTI in partnership with the Economist Intelligence Unit and the Johns Hopkins Center for Health Security is a global health security index, and whether it's possible to create one and using indicators not just indicators that relate to pandemic preparedness, but indicators that also track back to community health and the overall health system. And so we're just completing the pilot phase of this project, but hopeful that a tool like that would help look at all countries with a very transparent lens, so that better decisions can be made about who's at risk, and also what the real risks are. So we're including political risks, we're including a lot of the other factors that go into whether a country is prepared, which are not just factors that the governments themselves control.
Thank you very much. So I'm really sorry to keep you waiting. I'm going to ask you if you can just put your questions, all three, put your questions very crisply, and we'll get the panelists to respond and then close. Go ahead, sir.
Thank you. My name's Nanette. I am also an undergrad. I'm a sophomore in the college. So I've spent most of my life growing up in Ghana, and my question was about just what I've noticed. So I know that in Ghana there are very, very limited universities, and even with the universities we have, very few of them offer like medical programs or have research centers and whatnot. So that's obviously led to like a low doctor to patient ratio, and I imagine that a lot of underdeveloped countries experience the same thing. So my question is, what efforts, if any, have like international health organizations or member states and WHO made to like address this problem in countries? Because if there are no doctors, then how really do you implement like health reforms and whatnot? Thank you.
Okay, thank you.
Hi, I'm Matthew. I'm a freshman in college, and I was wondering, hearing all of these speakers has definitely only reinforced for me the need for funding for the WHO and for international organizations, and I fully sympathize with the need for that funding. But how do we bring these issues to the average American or the average citizen of any country, so that we can galvanize public support for these programs that seem, for a lot of people, I think, to be very far off issues? Thank you.
Thank you.
All right, I'm back. So Professor Sachs, I thought that it was really interesting that you used your introduction to talk about drug pricing, and you talked about the cost of manufacturing of a drug, but you didn't talk about the cost of drug discovery, and just how long, like simple statistics, like it takes 20 years to bring an idea to an actual marketed product, and the cost of clinical trials and all those things. So how can you finance the drug discovery aspect of the R&D process, and also incentivize, again, the R&D process, and still come up with drugs that are reasonably cost? I think that you would have probably some really interesting things to share on that. Thank you.
So thank you very much for those terrific questions. I'm going to ask each one of the panelists to respond to what they'd like to respond to, and make any closing remarks they'd like to make, starting with you, Dr. Schmidt.
I'm just going to pass to people who know the answers to the questions.
Okay, you have no other closing remarks to make?
No, I mean, I don't need to talk just for the sake of it.
Thank you.
I'll just be quick also on two points that don't perfectly answer the question, but in the interest of passing along information that might be helpful. In the case of doctor to patient ratio, I don't have the answer to the question about exactly what's being done to tackle that issue. On epidemiologists and some of the other training programs that I've focused on more in the global health security agenda, one of the answers to your question is that there does need to be a concerted effort, and having a standardized approach to that, and understanding what the actual core gaps are and where they are in the world, and how to actually tackle those gaps given all of, sorry, there's a big light there, tackle those gaps in the context of what your local needs are. That's critical. I also want to just point you, if you're interested in health security, Ghana has been very active and has some next generation leadership support there, and that would be an interesting place to plug into if you're interested in that. And then on vaccine development, one of the encouraging things that's happened over the course of the last year is the launch of the Coalition for Epidemic Preparedness Innovation, CEPI, which was launched to get at some of the questions that you raised. How do you actually shrink the time for drugs to get to market for core drugs that we really need better vaccines and therapeutics for? But in my personal opinion, a lot more needs to be done to get to the point where we actually have medical countermeasures and diagnostics on demand, which is something we've been talking about for years, but we are really, really far away from.
One quick point on the question of doctors and population. Because of mobile connectivity, telemedicine, and the advent of trained community health workers, there's a tremendous amount of innovative redesign of how health systems can reach everybody. And so we don't need doctors the same way as in a traditional system. We can have people doing outreach. You can have your radiologists anywhere in the world. Soon, probably there won't be even too many radiologists. Your phone will do the reading of the images. It will both take the image and do the image and interpret it through an expert learning, machine learning system. So there's a tremendous amount of interesting innovation going on, and I would really encourage students to work on systems redesign in an information technology-rich environment, because we can do a lot that was not even possible just a few years ago. On the question of R&D, I should have added that Gilead, in this drug that I mentioned, when it bought the product, probably the cumulative R&D that went into sofosbuvir was perhaps $500 million. Gilead is now earning about $15 billion a year on the drug. So the relationship between the R&D and the ultimate pricing is not very direct. It's not very rational. It depends tremendously on market power and on lobbying power. And there are multiple ways to get much better results, but we need what in the lingo is called rational drug pricing, which explicitly takes into account the R&D incentives and the access issues. The U.S. system right now says we'll basically go out and discover something, and then you have 20 years of monopoly, do what you want. And that system, under any theoretical conceptual terms, can hardly be what we call second best. It cannot be the right design. There are better, more rational ways to keep that balance. One way, by the way, is public funding and then open licensing of the medicines. And this company that I particularly despise, Gilead, for many reasons. I despise that they leave people to die. I despise that they keep their profits abroad in tax havens in a complete tax gimmick. And I basically despise they don't do R&D almost at all. I won't go into it. Anyway, we're not getting the best of this, and we're getting a lot of Me Too, what's called Me Too innovation, meaning a tremendous amount of duplication of the R&D efforts, because it's all designed in a pretty irrational way to chase high monopoly profit margins, not to chase social need. So let me just say that it's a lot of good considerations, good senior theses, good PhD dissertations, many trade-offs, but we're not even close to getting those trade-offs right now.
So thank you very much. Let me, in closing, thank President Lee Bollinger and Dr. Tedros in their absence. and Dr. Sachs, Cameron, and Schmidt for their superb and thoughtful contributions, and we certainly kept them till 6:45, as I have you. I'd like to thank Vilna Rivera Gallagher and Jennifer Ginrich from the World Leaders Forum, Peggy Dubner, Gabby Flynn, and Wantani Briggs-Lopez for helping us set up such a complex event, and to all of you for your interest in global health and supporting the WHO and other organizations advancing global health. I wish you a good night. Thank you for coming.